Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare on the Doc to Doc podcast.
Dear colleagues, I'd like to welcome you to another Miami Neuroscience Institute podcast, and I'm here today with Manmeet Ahluwalia, who is Chief Scientific Officer, Chief of Medical Oncology, and Deputy Director of Miami Cancer Institute. He holds the Endowed Professor Chair, the Fernandez Family Foundation Endowed Chair in Cancer Research. I'm Michael McDermott. I'm a neurosurgeon. I'm the Chief Medical Executive at Miami Neuroscience Institute. And today we're going to be speaking about a prospective clinical trial on the use of low-intensity focused ultrasound for non-small cell lung cancer brain metastases. Dr. Ahluwalia, could you give us a little background on the prevalence of this kind of tumor, non-small cell lung cancers, the gender distribution, previous treatment results, and overall survival? It's a big topic, but you got the ball.
Thank you, Mike, and so glad to be with you here today. So as you know, non-small cell lung cancer is around 80% of all the lung cancer that we see in the United States. It is one of the most common types of cancers. Over 200,000 patients are diagnosed every year in the United States. What we also do know that the most common stage in which non-small cell lung cancer presents is stage 4. That means the cancer has spread outside the lung, often can go into liver, bones, or brain. And we know whenever a cancer goes to the brain, it's not unfortunately good news. What we are excited about is that in the last decade or two, there has been tremendous progress made in stage 4 lung cancer, where on an average people lived around 12 months or so, almost 2 decades back, and now people are living over 2 years. And the 5-year survival has increased from 5% to 20 to 25%. Still, brain metastases continues to be a significant clinical challenge for these patients, and we'll address that. But you had asked the question regarding gender specificity. What we've been noticing in the last decade or so, that there's an increasing incidence of lung cancer in women, and particularly in women who are non-smokers. And there was a Nature publication in the last year or so actually showcasing that pollution, just small particulate pollutants, can actually lead to increased inflammation in the lung that can actually lead to non-small cell lung cancer. And in particular type, there's an oncogenic-driven lung cancer called EGFR, or epidermal growth factor receptor kind of lung cancer, where this leads to a particular increase in that. So on one hand, we are seeing a great improvements in outcomes, but on other hands, we are picking up new patterns of lung cancer, which may not have been either recognized or were not there at that level.
Yeah, that was my experience in my career in radiosurgery over the last 30 years. In the last 15 years, I've noticed an increase in the number of young women in their 40s and 50s who were never smokers, never exposed to secondhand smoke. And I guess we don't really know whether it's the inorganic or the organic particulate matter that's responsible for the inflammation. Now, a variety of treatments exist for patients with a small number of brain metastases when it's so-called stage 4, and that includes surgery, radiosurgery, whole brain radiation therapy, which is used much less commonly now. You're involved as a principal investigator for a trial BT012 using low-intensity focused ultrasound prior to the administration of pembrolizumab. Can you tell us a little bit about the trial, inclusion, exclusion, et cetera?
Oh, sure, absolutely. And, Mike, as you know, you've been one of the leaders in the radiosurgery aspect of treating brain metastases per se. And so there has been significant interest developing medical therapies and then finding avenues to help medical therapies get to the brain. So one of the challenges that exist for brain tumors or brain metastases, which is not there for other metastases, is this issue of blood-brain barrier, which is a lining around the brain that protects us from every time you have a blood infection, you may get a brain abscess.
Right. It essentially exists at the level of the endothelial cell and capillaries within the brain.
Absolutely. So what this trial is trying to do is it's trying to use low-frequency ultrasound to help disrupt the blood-brain barrier to increase drug delivery, but also using the ultrasound to actually help in something we think of as in terms of immune priming. So what we do know is even, for example, radiosurgery, if you use it, it can help to increase the new epitope expression. So in a way, you can help immune prime these cancer cells to augment the response of immunotherapy even further. So what this trial is doing, and you are integrally involved as one of the leading physicians at Miami Cancer Institute on this, is that we deliver the focused ultrasound and then we use pembrolizumab. And at the second intent, we're going to use pembrolizumab with a number of chemotherapies as a triplet combination to even enhance this further. And the hope is that the ultrasound can disrupt the blood-brain barrier, but also use immune priming to augment the immunotherapy impact we can get from pembrolizumab. Now, some trials have shown pembrolizumab may work well by itself, but not to the degree to replace the local therapies that we use like radiosurgery.
Yeah, it's interesting. You mentioned immune priming, and that reminded me of this so-called abscopal effect. You want to tell our colleagues about that effect?
Oh, sure. So, abscopal effect is something that we have been delving into for years. And Sylvia Formenti has done a fair amount of work in this as well. And basically what it relates to, if someone has a brain metastases, they have 3 brain metastases from, say, even lung cancer. And as a neurosurgeon, you may go and deliver radiosurgery or some form of radiation, maybe focused radiation, to the largest lesion. But you may not deliver it to the 2 lesions. But this combination of the radiosurgery or radiation along with immunotherapy may help increase or augment the benefit you may see on the 2nd or the 3rd brain metastases where you have not delivered a local therapy. And there have been New England Journal of Medicine publications in spine. Sometimes when you have radiated one portion of the spine, the second portion of the spine that you did not radiate will regress as well, sometimes beyond what you would just think with immunotherapy. So I think we're in a tremendously exciting era of scientific exploration. We are being able to measure things, which just makes it so exciting to come to work every day.
Yeah, one of the studies we did with Rupesh Kotecha, one of our medical student researchers, was looking at the molecular profile of the primary tumor versus the brain metastasis, and we found that they were different. Is that true of other, is it true in lung cancer? Is it true, I know it's true in melanoma and renal cell. Can you tell us a bit about how that might affect the results of the trial?
Yeah, so we use a term called subtype switching. So what we know is in breast cancer, for example, there are women who have hormone positive and HER2 positive disease. And sometimes we use therapies which is particularly directed against the HER2 with these targeted therapies, and there's a loss of the gene expression. So what we're finding out is that brain metastases have a different level of expression than what is seen in the primary tumor. So you mentioned about PD-L1 expression. We do know there is almost like a 15% discordance between the PD-L1 expression in the brain compared to what we are seeing in lung cancer. And sometimes it may be present one place, may not be present the other place. So it keeps the role of neurosurgeon important because we may want to go and actually sample those tumors.
We're not going to be out of a job anytime soon. That's good. Now, the preliminary work on low-intensity focused ultrasound showed significant elevations of drug concentrations inside the metastasis that were operated on after the administration of that treatment. But what about the brain immediately adjacent to the margin of metastasis, where there can be some microscopic infiltration depending on the pathology type, more common with squamous cell and melanoma, for example, than adenocarcinoma? Do you think that's going to be important, that increased drug concentration immediately adjacent in terms of local tumor control?
Yeah, I think it is. I mean, again, we have 2 concepts, right? We have a blood-brain barrier concept, and then you have a brain-tumor barrier concept as well. And, you as a physician scientist have, is something play a critical role in help us recognizing that. So what we do know is that we use trastuzumab, which is one of the monoclonal antibodies used against HER2 positive brain metastases from breast cancer. And Neil Lifsman and his group in Toronto actually did a radio-labeled assay to basically show that the concentrations of the drug in the brain metastases increased several folds when they used this low-frequency ultrasound. And as a result, we also saw tremendous clinical benefits in these patients. So that is one of the purviews of this concept with this trial, but also a number of other trial concepts that we're working on. But I think this concept of helping just the microscopic infiltration is going to be critical, and I would love to know your thoughts on it.
Yeah, I think it's not such a problem with brain metastases per se as it is with other tumors, primary tumors like gliomas. But thanks for mentioning Nir Lipsman. Shout out to him. He's a hometown boy in Toronto. And he's done a lot of pioneering work in both low-intensity focused ultrasound as well as high-intensity focused ultrasound. But can you give us a brief overview of your study, the BT012? I understand it's a prospective multi-center trial. Its randomization is 2-to-1 with the control group. And do you want to, I've treated 2 of the patients with low intensity, but for the audience, you can outline what the trial involves.
Yeah, first of all, I would like to acknowledge and thank you, Mike, for your leadership on this study, both locally and nationally with us, because we need to work together. It takes a village to take care of these patients, and you need the disciplines to work hand in hand, neurosurgery, radiation oncology, and medical neuro-oncology. So thanks for that. So the trial actually has got 2 aspects, and we are in the first stage where we just have to show the safety of the procedure along with pembrolizumab. And as you know, at Miami Cancer Institute and Miami Neurosciences Institute, we worked collaboratively to treat 2 of the 7 patients that have been treated so far on the trial. And so far, we have seen that it's fairly safe and extremely well tolerated. And I would love to, for you to share your experience. Now, the intent here is that can we build on the benefits that we would just get with immunotherapy or immunotherapy plus chemotherapy. So what we do know from prior trials is that when you use immunotherapy alone to treat these patients, we see response rates, which means shrinkage of the tumor by 50% or more in 30% of our patients. So what this trial is trying to see if we can double that, and we have a Bayesian design. That means we can alter the number of patients we treat on the trial on the benefit they are getting. So the first aspect of the trial where we are in right now is to showcase the safety of pembrolizumab along with LIFU. And then when we reach that, the second aspect is going to be LIFU plus pembrolizumab plus chemotherapy. But then we will launch into which we think is the exciting component of the trial, more exciting component, 2:1 randomization with LIFU plus medical therapy compared to just medical therapy alone, with the hope that the combination of LIFU and the medical therapy will be twice as effective as just the medical therapy.
Right. So obviously brain control is the issue here, not systemic control. And the radiographic responses, how are those going to be analyzed to avoid bias?
Yeah, sure. So great question, and we all struggle with it every day. And as you know, there has been an organized effort called RANO. And essentially what it is doing is looking at response rates specifically in the brain compared to RECIST. RECIST is something we use for the rest of the body. Right. But as you know, in brain, we have specific challenges on top. So RANO is a group of some of the top researchers, and one of your colleagues from UCSF previously, Suzanne Chang has been a national, international leader of that effort. And what we are trying to do is we're going to try to measure the response rates with immunotherapy plus LIFU. And we are building it that in a manner that sometimes with immunotherapy, you may have an initial increase in the size of brain metastases rather than a decrease. But as long as the patients are doing well, you can continue to treat them. But the ultimate hope is that the combination of LIFU plus immunotherapy is going to be effective in helping shrink the tumors more. And so it's a joint effort with the neurosurgeons and radiation oncologists.
So let's say the LIFU plus drug proves to be very effective compared to standard medical therapy. Are we going to put LIFU head-to-head with radiosurgery at any time, do you think?
So I think we hope we get to that stage. We still believe radiosurgery is one of the foundational ways to treat brain metastases. And there's a lot of data for that, either alone, but more interestingly, in combination.
Sure.
So the hope is if we can use LIFU to improve the response rates with medical therapy, the next iteration of trial actually will be a combination of radiosurgery, LIFU, and then the medical therapies, and hope that we can achieve in brain metastases what we have done things in like lymphoma. So for example, lymphoma is a great prototype of how initially we used to have one drug, then we went to 2 drugs, and now we are using combination of 4 to 5 drugs together. And here, as you know, brain, it's always multidisciplinary management. We do that for primary brain tumors, we do it for brain metastases. So I still believe that might be our best bet to help these people with long-term survival.
Right. So radiosurgery for induction and the LIFU and chemo for consolidation, so to speak, in medical oncology terms. Now, we know that breast cancer, lung cancer, melanoma, 3 of the most common tumor types. Is there a plan to investigate LIFU and chemo or immunotherapy with other types of cancers?
Well, the intent is that, but we did start with lung cancer. As you know, it's the most common cancer that goes to the brain. 50% of brain metastases that we see in clinic are from lung origin. The hope is to then go to breast cancer and melanoma. But ultimately, what we are recognizing is kidney cancer, for example, which is the fourth most common cause of brain metastases, is now being treated with a combination of immunotherapies as well, very similarly to how we are treating non-oncogenic tumors in lung cancer. So I think we will get to a state that we will have combinatorial therapies based on how we treat diseases rather than the organs that diseases arise or these cancers arise from.
Yeah, with the advent and progression and discovery using monoclonal antibodies for cancer, some of us were worried that the medical oncology group was going to try and treat brain metastases with chemo or immunotherapy alone. And I believe there are studies out there that looked at immunotherapy alone versus immunotherapy plus radiosurgery. And maybe you want to comment on those.
Yeah, no, absolutely. So, we and others have done several studies, whether they've been retrospective analysis or data collection from multiple other efforts. So I can particularly highlight a German effort of 23 centers across Germany, where they treated 380 patients with brain metastases. And these were treated by the best choice based on physician recommendations. And so there was a group that was treated with immunotherapy alone, but they used the dual checkpoint inhibition of ipilimumab and nivolumab. And then a number of these patients were treated with radiosurgery along with immunotherapy. And what we found out was that people who were being treated with radiosurgery and immunotherapy had better outcomes in the ballpark of 24 months compared to 16 months for just with immunotherapy, highlighting that local therapy is still extremely important in management of brain metastases. And similarly, Rupesh Katocha, who you named before, when he and I were both at Cleveland Clinic, we had looked at our Cleveland Clinic experience of around 150 patients with lung cancer, with brain metastases, where we found out was that if radiosurgery and immunotherapy was given concurrently or very close to each other, we got the highest number of complete responses. That means that brain metastases disappeared completely, resulting not only in improved complete response rate, but also increased in overall survival in those patients. So we have at Miami Cancer Institute, but also at several leading academic centers around the country, like to handle these patients in a multidisciplinary manner with a combinatorial effort of radiosurgery with targeted therapy or immunotherapy as needed for that particular patient.
All right, let's reverse the tables. Ask me a question about recurrent brain metastases, lung or otherwise. Do you have any questions for me as a neurosurgeon?
No, absolutely. I mean, I think there are still some critical aspects of research or treatment that we need to find. So one is we treat traditionally our patients with upfront brain metastases with radiosurgery, often with combination with immunotherapy or targeted therapy. When these patients fail and they come to you at a referral center, maybe they were treated somewhere else, what's your approach to treat these patients? And what do you have in your toolbox?
Yeah, well, one of the first things, of course, is to determine treatment effect versus recurrent tumor, which is often difficult. And we, of course, review these at radiosurgery conference every Wednesday morning. But the other aspect is, if the patient's symptomatic and has a lot of edema associated with the metastasis, then repeating the radiosurgery, although repeat radiosurgery has been shown to be effective and safe, in the setting of acute symptomatology and a lot of edema, repeating the radiosurgery is only going to make things worse. So in those patients, we actually consider reoperation with brachytherapy. And I actually started doing brachytherapy in 1989, I'm afraid to say. That was a long time ago, but I still do it. And I think we've multiple publications on it for brain metastases. Brachytherapy failed in the prospective trials for malignant glioma, and largely because of the associated toxicity. Now we're investigating, cesium-131, which is a shorter half-life, lower toxicity profile than iodine, which we used in the past for glioma. So we'll see. That's a more difficult nut to crack. But for recurrent brain metastases that are symptomatic, the reoperation and brachytherapy is actually very effective. The edema resolves almost completely in 3 to 6 weeks. One of the critical things, we were talking about treatment effect versus recurrent tumor, we have to get a pathologic diagnosis intraoperatively of viable tumor before we can do the brachytherapy implant. So there's about a 20-30% incidence where we think it's recurrent tumor, reoperate, we find it's radiation necrosis, and we stop there, take out the radiation damage. That's also an effective form of therapy for radiation necrosis, is surgery. So anyway, I'd like to thank the audience for their attention today. That brings us to the end of this podcast on the use of low-intensity focused ultrasound and a clinical trial for non-small cell lung cancer brain metastases, using it in combination with pembrolizumab. And physicians interested in referring patients for consideration of the trial should contact Julia Montoya at 786-594-7354. And thank you again.
Thank you, Mike.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.